Respected dignitaries on and off the dais, my dear friends and colleagues. Let me first take this opportunity to thank the organizers for allowing me to present this topic in front of this august audience. I am asked to talk on fractures of distal end of femur. As we all know, it's a complex fracture, and then it's intra-articular, and many a times it could be an open fracture as well. Around 6% of these femur fractures are constituted by the distal end of femur fractures, and majority, around 50%, are intra-articular, and it occurs mainly in young patients, and as a part of high velocity injuries. So this all adds to the importance of this fracture. If you want to understand the treatment, it's of course important to know at least one good classification. This is a good classification. AO classification type A is extra-articular, B is partial intra-articular, and C is intra-articular and extra-articular. The aim of the surgery is not only to produce a good articular reduction and stabilization, allowing early mobilization, but sometimes it is life-saving as well as limb-saving, because many a times the neurovascular bundle is so near and you could have a vascular injury as well. So you should look for that. The deforming forces are the quadriceps pull, which cause shortening, the adductors, which cause varus, and the gastrocnemius, which cause recurvatum. So when you reduce this fracture, these three forces you should bear in mind. And you should also think of the geometry of the distal end of femur. We all know that it is trapezoidal. There is a slope here, and on the lateral side also you get a slope which is around 10 degrees. So if you want to put the correct implant, you have to angulate your primary fixation device at least by 10 degrees. Otherwise, you are not going to get the good bone stock and your fixation. So this point you should remember. When you fix your primary implant, it should be at least 10 degree internally rotated. That gives a good bone perch for you. And if you draw a line along the shaft of femur, majority of the part of the distal femur is posterior to the axis of femur. And if you want to get good bone perch, you have to put your primary fixation device at the junction of the anterior 1/3 and middle 1/3 of the distal femur. If you go posteriorly, you are going to get a failure of fixation. So this is the same point I would like to repeat again. If you draw a line along the axis of femur, majority of the part of the distal femur is posterior. So you have to have your fixation device rightly centered around 1 to 1.5 centimeter above the articular surface at the junction of the anterior 1/3 and middle 1/3 of the bone stock of the distal femur. This gives the best perch for your primary fixation device. So if you don't do that, you are going to produce a tilt at the anterior, medial or varus, and you are going to get a malreduction after your fixation. If you want to treat this fracture, you need a good quality X-rays, you need a traction X-ray as well, but it is important to have a CT scan. You have to have a good 3-dimensional CT scan to know the exact placement of your fixation device, then only you will understand the personality of the fracture. What is the surgical timing? You have to respect the soft tissues. If you are in doubt, you put a spanning external fixator, wait for some time, and then only you go for your fixation, otherwise you are going to be in trouble. While you fix, position the patient supine. The knee should be at least 10 to 20 degree flexed. This will somehow reduce the pull of the gastrocnemius, and this is the good position, and the best approach is a lateral approach, because you can go as high as the upper third or even middle third, you can go high, and you can even use a jig for your minimally invasive surgery as well. So the standard procedure is a lateral approach, and it is a lateral para-articular, or here you are going to use a parapatellar approach. Here you are going to expose the fracture very easily, and you get a good reduction as well. In a type of fracture, you can use a antegrade nailing or a retrograde nailing. So these are the fractures which are easy to treat, but you can also use a conventional plate. When you treat the intra-articular fractures, treat the coronal fragments first, then go for the intra-articular fragments, then only go for the extra-articular fragments. That will only give you the good articular reconstruction. The conventional plates are inexpensive. The advantage is that you can use the plate for reducing the fracture, which is not possible with the advanced plates. So here you can have a reduction even once you plate, but with a locking plate you have to get the accurate reduction before you plate. So that is one advantage of this, but the disadvantage is that when there is a medial combination, it's going to fail. When there is osteoporosis, it's going to fail, and it fails to prevent the varus force. In a type B fracture, it's a partial intra-articular fracture, you can use a fixation device, fix the coronal fragment first, then fix the articular fragments. This is a Hoffa's fracture, and this is a partial intra-articular fracture fixed using screws. Other fixation devices are the dynamic condylar screws or the blade plate. But when you fix your primary fixation device, you can use this summation technique. One K-wire along the anterior surface, one along the posterior surface. A K-wire in between the two parallel will give you the best position for your fixation device. This is known as a summation technique. So this can be used to put your compression screw, but these screws should not interfere with the primary fixation screws. Again, the principle is coronal fragment first, articular fragment second, and extra articular fragment the third. Now this device is not nowadays used, but still if the quality of the bone is good, this is a good fixation device, a blade plate. So the first step, I will repeat again, reduce the coronal and sagittal fragments and then go for the extra articular fragments. And the junction of the middle third and anterior one third, this I already mentioned, that is the site where you should aim your primary fixation device, not here. If you aim here, your surgery is going to fail. So lateral plating is the best one, even for the locking plate. The advantage is that you can do an arthrotomy, get the good reduction, and then you can use your jig high up to the, even up to the upper third to get the best reduction. So you can use a arthrotomy here, reduce the articular fragments, then you can use your jig to produce a minimally invasive fixation. So it can be done like this. You do an arthrotomy, get a good reduction here, then only you put your plate. This plate cannot be used to reduce the fragments. So you have to get the best reduction and then go for the plating. And here you are going to do the articular reduction, to do an open arthrotomy, you get the articular reduction, get the length by distraction, and you correct your each fragment reduction by your joystick technique. You can use a K-wire which will help you to reduce each and every fragment. So you are going to get a fragment specific fixation and the best articular reconstruction. Once you get that, then it is easy for you to get the extra articular fixation. You can use a jig here, and this jig can be extended up to here, and you get the most less invasive fixation using a locking plate. So this is probably the best fixation device nowadays available for fixation of these fractures. The advantage is that it prevents the medial collapse, it prevents the varus collapse, and you get a good range of motion as well. So this is a locking plate with a good union in an osteoporotic fragment. If you use a conventional plate, the disadvantage is that it can result in a varus collapse and varus deformity. If you do that, you have to buttress the medial fragment as well with a medial plate. You are not supposed to expose a bone like this or like this. This is not good for fracture union, and it will result in a very bad result. So try for a less invasive fixation. Other problems in the distal of femur are with a process in, you can use an antegrade nailing or a retrograde nailing, and then you can fix epiphyseal fractures as well very easily. When there is a bone defect like this, you can go for a fibular graft and fixation, and you can use even a cage. So a lateral locking plate, a buttress plate here, non-locking buttress plate. Now the problem is a varus collapse, I told. So how to solve it? You can use a medial buttress as well. So this has been published in JBJs. You use a medial buttress plate, lateral buttress plate, and this is an accepted method. It has been published in the year 1991. Now if you go for such a fixation, it is better to go for a midline incision, and then you can approach from either side. But the more you injure the medial muscle, the more stiffness you are going to get. If you do a current concept review of the literature, you will come to know that the angle blade plate gives the maximum amount of malunion, and the other fixation device are less. So this device is gradually disappearing from the market. So the take home message is meticulous preoperative planning. Study every fragment well. Deforming forces must be kept in mind. Get the reduction and then fixation, not for the reduction second. Thank you for patient listening.